This is Dr. Suchard, back again for a video discussion about sedative hypnotic drugs, corresponding to Chapter 72 in Goldfrank's Toxicology Emergencies. The learning objectives for this session are that you'll be able to describe the mechanism of action shared in common by most sedative hypnotic drugs, outline a typical clinical management plan for sedative hypnotic toxicity, and, probably least important, to identify some potential yet rare additional treatments that could be used for barbiturate and benzodiazepine toxicity. As mentioned elsewhere in this video series, there's a recurring theme in pharmacotherapy where a new drug class has its heyday, but is then replaced by a newer class of agents for the same indication, which takes over probably because it has a better side effects profile. And we can see the same thing with the sedative hypnotics. Bromide salts were first marketed in the 1850s as sedatives and were popular well into the 20th century. But they were associated with skin eruptions called bromoderma and were responsible for what is now a surprising incidence of psychiatric symptoms, so much so that bromide use was estimated to be responsible for 5 to 10% of all psychiatric hospital admissions. Barbiturates were introduced in 1903 and were hugely popular, but they caused a lot of dependence, and their narrow therapeutic index meant that overdoses could be particularly dangerous. The next generation were the benzodiazepines starting in the 1960s, and these are still quite popular. I will mention here that the chapter does cover a few agents outside of this chain of most favored sedative hypnotics, such as chloral hydrate, meprobamate, and carisoprodol, but these are rarely encountered and essentially obsolete, and we're not going to spend any more time on them here. Sedative hypnotics are really described by their effects more than by their mechanism, and the resulting sedation, sleep, or maybe even coma, without much else going on, is the least flashy of the toxidromes. Occasionally, with severe exposures, you can have concerning vital sign abnormalities, but mostly the patient is just less responsive. Sedative hypnotics generally work at the GABA-A chloride channel, where they bind to augment the action of GABA that opens these channels, letting negatively charged chloride ions into neurons, which hyperpolarizes them and makes them less likely to generate or propagate action potentials. In this graphic of the GABA-A channel, we see that there are multiple sites where benzodiazepines, barbiturates, and the Z drugs can bind. And these three are the subclasses of sedative hypnotics we're mostly going to focus on. A few decades ago, barbiturates used to be a lot more popular than they are today. But one of the things that made them pass from favor was that they were responsible for a large number of overdose deaths. And this is probably because they don't have a ceiling effect on respiratory depression. In the absence of ethanol or some other complicating factor, it's hard to take enough benzos to make you stop breathing. But this was a lot more common in overdose with barbs. And some notable celebrities who reportedly died from barbiturate overdose include Marilyn Monroe in 1962 and Jimi Hendrix in 1970. Just like how the toxidrome of sedative hypnotics is not flashy, the management of sedative hypnotic overdose also is not flashy, consisting almost entirely of supportive care measures. If the patient isn't breathing well, you intubate them and breathe for them. And then you make sure no other complications occur, so you keep them hydrated with IV fluids and pay attention to the potential for bed sores and venous thromboembolism. With barbiturate toxicity, which we don't see much anymore, you may consider urinary alkalinization to promote renal elimination, or even hemodialysis in select severe cases. And for benzodiazepines and the Z drugs, you might consider flumazenil a reversal agent. You might consider it, but you probably wouldn't use it. See the other video in this series about flumazenil. Now, these Z drugs I've been mentioning include zolpidem, zaloplan, zopiclone, and S-zopiclone. These drugs are not benzodiazepines because they don't share the same basic chemical structure that defines a benzodiazepine, but they bind to the same site on the GABA chloride channel and have similar effects. Currently, these Z drugs are popular sleep aids, supplanting benzos for this indication. Again, mostly because they have a more favorable side effects profile. The chapter mentions a few additional sedative agents that are, or at least should, only be used for anesthesia. And since their use is typically IV and limited to monitored acute care settings, we don't see a lot of people overdosing on them outside of the hospital. Propofol is very commonly used for anesthesia, and patients may be placed on propofol drips, some of whom can develop the propofol infusion syndrome. Michael Jackson's death in 2009 was ascribed to propofol. He used to receive IV propofol in his home, prescribed by his non-anesthesiologist private physician to help him sleep. Seems like a bad idea. And I mentioned etomidate here, which is also used IV to induce anesthesia. If you use a single dose, which is common to induce anesthesia, there shouldn't be a problem. but repeat doses and infusions of etomidate may cause adrenal suppression, which can complicate those patients' care. Lastly, while sedative hypnotic overdose is often relatively benign, since we're talking about benzodiazepines which have a ceiling effect on respiratory depression, withdrawal from sedative hypnotics can be life-threatening. Chronic exposure resets the amount of GABAergic tone, and when the sedative hypnotic isn't there anymore, there's an imbalance and there's not enough GABA-A chloride channel-related hyperpolarization, resulting in uncontrolled depolarization, potentially causing intractable seizures. That's all I have about the sedative hypnotics. I'll be seeing you around.